All right, welcome. Today, we're diving into hypertension treatment. We're going to break down exactly how doctors figure out the right starting medication for their patients.
So let's kick things off with a big question. If high blood pressure is one condition, why isn't there just one go-to pill for everyone? Well, the answer really gets to the heart of how personalized medicine works today.
And to figure that out, we're going to walk through it just like a doctor would. First, we'll get a handle on what hypertension is and why it's such a threat. Then we'll look at the standard first-line drugs. After that, and this is the key part, we'll see how special cases change the game, which leads us right to beta blockers and their unique role. And finally, we'll wrap it all up. Okay, first up, the silent threat. Before we can even talk about treatment, we have to understand what we're dealing with and why getting this right is so important.
The key word here is persistently. We're not talking about a high reading you get after, say, rushing to an appointment. We're talking about a chronic condition where your entire circulatory system is under constant, relentless stress, day in and day out.
Now, blood pressure isn't just a single number. It's classified into stages based on two readings: systolic, that's the top number, and diastolic, the bottom number. You can see how these stages, from normal all the way up to stage 2, give doctors the first critical piece of the puzzle for deciding what to do next. And the reason this is taken so seriously is, well, this. This isn't just about numbers on a chart. If you leave it untreated, hypertension is a major driver of strokes, heart attacks, and even total kidney failure. That's why treatment is absolutely non-negotiable.
Okay, let's move on to the good news, the treatment. So, when a doctor decides it's time for medication, what's the typical game plan? What's the starting move?
For the vast majority of patients, treatment starts with one of these four main classes of drugs. You've got ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics. Now, they all work a little differently, but the end goal is always the same: lower that blood pressure and cut the risk of those scary events we just talked about.
And the opening mood is pretty straightforward. It all depends on that stage we saw earlier. If a patient's in stage 1, you'll usually start with just one medication from one of those four groups. But if they're in stage 2, where the pressure is higher, the guidelines say to start with a combination of two drugs right out of the gate.
Now, this is where it gets really interesting. What happens when a patient is dealing with more than just high blood pressure? What if they also have, say, heart disease or diabetes? This is where the one-size-fits-all approach goes out the window.
The key idea here is something called a compelling indication. Think of it like this. It's when another health problem a patient has compels the doctor to choose a specific drug. It's like a 2-for-1 deal. You pick a medication that treats the blood pressure and gives a special proven benefit for that other condition at the same time.
And this roadmap here shows that logic in action. Don't worry about the tiny text, just follow the arrows. See how the path for a patient with diabetes is different from someone who's had a stroke? The starting drugs change. It's not just about getting a number down anymore, it's about picking the perfect tool for that specific person's overall health. So all of this brings us to a really important class of drugs: beta blockers. And it takes us right back to our original question. If they lower blood pressure, why weren't they in that main group of 4 for everybody?
Well, you don't have to take my word for it. This quote from the medical guidelines makes it crystal clear. Beta blockers are reserved. They're not on the starting lineup for simple hypertension. They're specialists, brought in for those very specific, compelling indications we were just discussing.
Let's go back to that roadmap. This time, look for where beta blockers show up. Right here. See this? For patients with heart failure or stable ischemic heart disease, that's when the heart muscle isn't getting enough blood, the path starts directly with a beta blocker. And why is that? Because for these specific people, beta blockers do something amazing. They don't just lower blood pressure, they actively protect the heart from more damage. That is a compelling indication. This chart sums it up perfectly. On the left, you've got the very specific, very serious heart conditions where beta blockers are the life-saving first choice. And on the right, that's their other job, as a secondary, add-on therapy for patients who don't have those heart issues, but just need a little extra help getting their numbers down. Okay, let's zoom back out and put a bow on this. What's the big takeaway from this whole decision-making process? The bottom line is this: modern blood pressure treatment is not about finding one best drug. It's about being a good detective, looking at the patient's entire health picture and choosing the exact right tool for that specific person. It's all about personalization. And that leaves us with a final thought to chew on.
The doctor can create the perfect, most personalized plan in the world, but it all comes down to the patient. So how does sticking to that plan, or not sticking to it, ultimately shape the entire course of treatment? It's a powerful reminder of the partnership that has to exist between a doctor and their patient.